So we're going to talk about trauma considerations today and dealing with a patient who has had some sort of trauma. We're using our mannequin today to demonstrate. And in your book it says the definition of trauma is severe injury or damage to the body caused by an accident or violence. Most common are falls, followed by motor vehicle accidents, and then firearms rank last in cause of injury, however, they're normally fatal. Trauma injuries can occur by several types of forces, including blunt, penetrating, explosive, and heat. Examples of blunt trauma are motor vehicle traffic accidents, which include motorcycle accidents, collisions with pedestrians, falls, and aggravated assaults. Penetrating trauma includes gunshot wounds, stab wounds, impalement injuries, and foreign body ingestion or aspiration. Explosive trauma causes injury by several mechanisms, including pressure, shock waves, high velocity, projectiles, and burns. Heat trauma includes burn injuries, which may be caused by numerous agents, including fire, steam, hot water, chemicals, electricity, and frostbite. And if you work in a level 1 or a level 2, even a level 3 trauma center, you're going to encounter patients who are in some type of immobilization precautions. And so we're going to demonstrate a few considerations today that you should have when moving and positioning a trauma patient. It's important in trauma cases to wear gloves. Frequently there is going to be blood or body fluid. It's typical in head injuries for patients to vomit. And so you always want to have your whatever protective body apparel is appropriate for the scene. Right now we're going to assume that maybe this patient has a little bit of blood because they've got some suspected limb fractures, as well as maybe neck or spinal injury. And so normally a patient immobilized like this would come in on a backboard. However, they're locked in a cabinet in the hallway and I can't get access to them. So we're going to pretend that she has already been taken off of the backboard, maybe had some portable imaging in the emergency room, and now she's in the radiology department, and we're going to transfer her onto our x-ray table to get additional images of her neck, upper and lower spine, her shoulder, forearm, and tib fib. So typically this would be at least a 3-person move, if not 4-person move, because normally you would have 2 people or 3 people rolling the patient to place the slider board under them, and then you would have another person at the head of the patient turning the head with the body rotation to make sure that the head always stays in alignment with the body, because we have not ruled out a neck fracture yet. So most of you have probably seen or used a slider board or a slick board. It's not stiff enough to hold body weight to pick up and move, but it does make a nice mechanism for sliding from the gurney to the x-ray tabletop. And like I mentioned, normally in a move like this we would have 2 to 3 people, 1 at the head and 2 on that side, but we are a quarantined family, and so I just have my husband. Okay, so you would log roll the patient, 2 or 3 people on one side, turning the body as a single unit, and then someone be on this side, sliding the board halfway under, and then we would roll the patient down.
1, 2, 3.
Okay. Then we would get the gurney next to the x-ray table, always keeping in mind that every time you move and position in a different way, you have to lock it. And so from here, again, someone would be at the head of the patient, and then we would use the slider board to move the patient over onto the table. And when there's a fractured limb, you might also have someone just supporting that limb by itself. Now, I normally will keep a patient on the slider board just because it's more trauma to the patient to roll them again to get them out. And so I just keep the patient on the slider board. One thing to always keep in mind too is that you would normally have a clean tech and a dirty tech. Someone who is just dealing with the patient and touching them, and someone who is behind the control panel setting techniques and possibly positioning the tube. That way you're not constantly changing your gloves. Now, I'm not going to demonstrate a glove change, but I will talk about it when it's appropriate. If I was by myself, I would do everything with one set of gloves on, and then when I was done, I would wipe everything down. But if I tag team with another coworker, I can limit that cross-contamination between bloody patient and equipment. So you also need to have a plan set up if you've got multiple imaging that you're gonna do from head to toe. You typically want to do all of the AP from head to toe to start with, and then turn to your cross-table laterals and work your way back up. That way you're not moving the tube back and forth, you're not moving the patient back and forth, you're keeping their comfort and your efficiency in mind. So we're going to assume that this patient has a CT and L spine, a right lower leg, and a right forearm. So those are the positions I'm going to be demonstrating today. Obviously, trauma can occur anywhere in the body, but extremities and spine are common, as well as chest and pelvis, but those don't really differ too much from what we've already talked about. The pelvis would be done as you learned it, except with no internal rotation of the legs if there was leg or hip trauma. So I'm not going to cover pelvis today, and I'm not going to cover chest, but we're going to talk about techniques to stabilize and safely move the limbs during a trauma exam. So we're going to start with our AP C-spine. And again, if I'm by myself, I've still got these gloves on, but I'm going to wipe everything down when I'm finished. All right, so I would set up as for, we talked about the C-spine already. Placing my right marker and continually assuring the patient that, you know, we're moving as fast as we can. Let us know if something hurts. You want to keep an eye on the patient. Look for signs of shock, cyanosis, anything that would indicate that the patient, that you would need to call in a nurse or physician. Now, you can read about trauma in your book. I think it's chapter 12, and then I'll cover all of this in the lecture. All right, so he's got a C-collar, she has a C-collar on, so I'm not going to be, what's wrong with this thing? I'm not going to be moving them at all. Not much palpation can really happen. Some C-collars have openings like this one, some don't. But you estimate where C4 is, and you can kind of gauge the top of the C-spine by the bottom of the ear. So I would take a projection like that. Also, many times trauma patients are unconscious or have an altered level of consciousness, and they cannot cooperate or understand breathing instructions. So it's important to use a really low time so that you can capture between breathing. And so I would go behind the panel and I would watch this patient's respirations and try to capture it during the least amount of movement. All right, so I've done my C-spine x-ray now. I would change out my cassette. I would reset this up for a open mouth x-ray. And this time, because I cannot adjust or tuck or extend the chin, I would be looking, yeah, you can come around here. I would be looking at where the mastoid tip is, and she could open her mouth. I could see where her teeth are. So it looks to me like from mastoid tip to bottom of teeth, there is a slight angulation. If this patient wasn't wearing a C-collar, I would extend her chin up, but because I can't do that, I'm going to match that occlusal plane with my CR. Okay, once I have that established that I'm parallel with the occlusal plane, then I would center and then collimate down to just the odontoid. I've left it open wide enough to include my marker that I've placed down here. If the patient can open their mouth, I would have them open their mouth. If they couldn't, some departments will have like a radiolucent bite guard, and you could actually part the patient's jaw and put that bite guard in, and then take the x-ray right through the bite guard so that the teeth are out of the way. So we're moving on to our AP thoracic spine. I have my 14 by 17, my right marker. You'll notice that I'm at a little bit longer SID because typically trauma patients are on backboards, which elevate them off the table. And so you need to increase your SID to compensate for that. Again, I would ask permission to palpate if the patient were awake. I would make sure that their mid-sagittal plane is as straight as I can get it. Center for thoracic spine, around T7. If they can hold their breath, I would have them. After I did the AP thoracic, I would move to the AP L spine and do the same thing. Before I go into the cross-table spine work, I'm going to assess, at least in an AP view, their extremities. That way I can know what kind of fracture I'm dealing with and determine how best to support the limbs during the cross-table spine work. This is where ideally you do need a second tech, because the limb needs to be supported while a second tech is putting the bagged radiographic plate under the limb. So I would have my coworker come in, support the arm proximally and distally in, and you lift it only as much as is required to get the cassette under them. At this point, it really doesn't matter if you have perfect alignment because we're just trying to get this done. So I want to make sure that I've included the wrist and past the elbow on this. My patient's size affords that, so then I would set up, and again, I'm moving everything rather than having this patient move. So I would adjust it. I would place my right marker in the field of view. Generally, we forego shielding on trauma patients because obviously the benefit of getting these x-rays outweighs the risk. But if I had a known pregnant patient for trauma, I would be shielding. And So just for the sake of the demonstration, know that you still follow department protocol in terms of shielding on a trauma patient. So if I could, I would throw a lap shield up here, expose her right forearm, okay, and then my coworker would come back in, again, help support the limb so that I could take this out, all right. Then I would bag another cassette. I would move on again and still be doing all the AP projections. So they would support the leg, only lift it up as much as necessary. And if I had a long patient, I might need to angle this diagonally to fit both joints. Okay. Place my marker, shielding, again, pull the tube over, centered. You guys, we've been through extremity work. This is really just demonstrating the need for you actually supporting the limb, and then, you know, also if the patient was conscious, letting them know what you're going to be doing. So we've done the APs. We're gonna bring our second pair of hands in here, pull the cassette out. Alright, now what I would do is with sheets or some type of protected sponge. Now I finished all my AP views. I'm going to start at the bottom and work my way back up again. So I would have someone lift the limb, and I would place sponges or sheets or whatever you have available under the limb to elevate it. Okay, and you want to keep the sponge inside because I'm going to set my cassette here, and I don't want there to be a sponge overlapping. So now the leg is resting. I'm going to take my IR. You can use a cassette holder for this. Typically you're going to see that they don't. What they will commonly do is just set the cassette on edge, and if there's difficulty in balancing it, they'll take some tape from one side of the table to the other just to hold it in place. But this is balancing pretty well. Again, if I was the only one, I would keep the same set of gloves on and change them and wipe down the whole room afterward. If I was the dirty tech, I would keep my gloves on and have the second tech come in and do this. But you'll learn all the aspects of this in your clinical rotations. All right, so now we're moving this into place. I'm gonna try to get 40 inches if I can. So I'm gonna move this back as much as possible. Maybe slide the backboard if I can to try to get 40-inch SID. I'm going to angle this a little bit because the cassette was turned, so I want to be perpendicular to it. And center to the leg and to the center of the IR. Change my collimation. Okay, I would place my right marker inside the field of view and expose. Now we're setting up for our cross table forearm. Again, I don't quite have 40 inches, but sometimes you are in a situation where you can't get the ideal SID, but we do the best, we do the best we can. So this is a situation where, you know, if I had medical tape, I would run it from one side of the bed to the other to ensure that the cassette stayed in place. All right, so I'm at max SID here, and it looks like I'm past her wrist and her elbow. So if I wasn't, I'd have to take a second shot to include above the elbow, but I think I've got it here. Now this isn't normal lateral forearm. The patient's in an AP position, but their arm is rotated completely anatomical position. So from a horizontal beam, this should be the equivalent of a lateral form. All right, so we're gonna slide the patient over to this edge of the board. I'm gonna get her all the way to the edge. Whoops. Okay. Now this can also be done on the gurney against an upright wall bucky. That's completely normal way to do this, and that may be the way they do it at your clinical setting. But we're going to demonstrate with the film holder, and assuming that they are on a backboard, I would slide this under the backboard. So for the thoracic spine, positioning wise, again, I want to come in around the level of T7. So I'm placing the upper border of my IR about even with her shoulder. Okay. Try to get 40-inch SID. Now, what to do with her broken arm? If you think about it, the thoracic spine is at the very posterior part of the body. So if I'm able to elevate her shoulder and her arm just a little bit, I should be able to clear the back of her body. So that's what we're gonna do here. Okay, we're gonna be raising your arm. So support the limb as much as you can. Elevate the shoulder and the arm. Okay, so now I've cleared the back of her spine. So I should be able to come down, and I can tell here that I'm below her C-spine, which makes sense because the C-spine has lordotic curve, thoracic spine has a kyphotic curve, so it's just off the bed. So I'm going to be pretty posterior here. Okay, and I'm going to collimate what I consider to be not much past the thoracic spine. I can place my marker down low so that it's above her thoracic spine, but still on the image. And if the patient could hold their breath, I would have them exhale and hold their breath. If they couldn't, I would try to capture them on expiration. Okay, now we're going to move down to the L spine. So now with the L spine, we're going back to the lordotic curve, which means I need to raise her arm even more. So I'm going to get a second sponge so that the arm is now above her L spine. Send her to the cassette. I'm at the level of her crest. I'm going to gauge where my mid-coronal plane is. Collimate. My left marker's on there. Maybe a little bit higher this time. And again, try to catch the patient in between respirations. So this is how you would do cross-table spine imaging if you had an injured extremity. If both arms were traumatized, I would be elevating both arms up and maybe trying to cross them on the abdomen just a little bit. you really just have to be creative, and you're gonna learn good tricks of the trade from the techs that you work with. So the cross table lateral C-spine is typically one of those images that's taken portably in the emergency department, but we can still demonstrate it here. So normally we would have our patient upright. In this instance, she's on a backboard. So we're gonna do this cross table, but we're still gonna keep the upper border of our IR at the top of ear attachment. I wanna see if the center is roughly about C4. I'm gonna try to get 72-inch SID, which in this situation is not possible, but I'll collimate. And because we do have one injury here, what I'm gonna do is try to just depress her shoulder as much as I can, and then I would ask a technologist, maybe a ED physician, someone else who is willing to put on a lead apron, and I would have them pull traction on the arms. Now we can't pull traction on this arm, but perhaps we could grab the splint, and then he also could grab the patient's other hand. Okay, so this x-ray requires that we have your shoulders down as much as they can be. So I'm gonna have him pull on your arms for this exposure. Just hold very still. I would have my left marker on here. I try to be at 72 inches. I'm centered at the level of C4 and mid-coronal plane. And then at the moment of exposure, I would say, okay, pull down on her arms. He would pull, give as much traction as possible, expose. Okay, you can relax. That really helps hopefully depress the shoulders enough so that a swimmer's view does not have to be done. But if it didn't work, we could do a swimmer's view cross table by elevating the unaffected side. So in the scenario where perhaps it was her left arm that was injured, then I would probably wait to do the swimmer's view until I got her back on the gurney, and then maybe put her up against a wall bucky, or from the gurney I would bring the tube to the other side, because you still want to elevate the arm that's closest to the IR. And in this setup, this is the uninjured arm, so this works well. So in this case, I would elevate her uninjured side. I would move the center of my IR now down to the level of the sternal notch, which is around C7, T1. This can be done at 40 inches. Okay. Again, if I cannot depress this shoulder enough, what I could do is throw maybe a 5-degree caudal angle in the tube, so that now I'm coming up and over her shoulder, exiting at the center of the IR, and then expose when it looks like I've caught her between breaths. So there's a lot more to learn about trauma radiography, but you'll get that in the clinical setting whenever we go back to life normal. But in the meantime, just review the video, think about the considerations, read chapter 12 on trauma, because it really is a very unique skill set that every radiographer should have. Okay. And if you have questions after watching this, please email me.